Yes. All right, here. Okay.
This is Jim. Please leave a message.
At the tone, please record your message. When you have finished recording, you may hang up or press 1 for more options. To leave a callback number.
Okay, we're going on here. 31 seconds.
Okay.
Bad. I'm going to go with the auto on the white balance. Is Kirsten not coming today?
She's right now coming in the door.
Hello.
See right there, Kirsten.
Thank you. You have Dunnigan on the phone?
Not yet.
Utah has the best of the best lawmakers in the nation. This is the Utah Legislative Update with Senate President Wayne Niederhauser and guests. If you have a question or comment, please call the Rock Canyon Studios at 1-800-776-1913. 1-800-776-1913 on KHQN and Channel 17.
Good morning, everyone, and welcome to the Legislative Update. This is Senator Wayne Niederhauser, President of the Utah Senate, and today we're going to be talking about the Affordable Care Act, or the ACA, affectionately called ObamaCare. Hopefully I'll have with me Representative Dunnigan on the phone, and we're trying to get a hold of him. But there's been a lot of discussion about the ACA lately, especially as the exchanges have come on board, the National Exchange. And here in Utah, we've had an exchange for many years. And
Jim.
okay, we got Representative Dunnigan with us now.
Hi.
Good morning, Representative.
Morning, President. How are you?
Doing good. We're on the air right now. We're just got started with a lead-in onto the Affordable Care Act. One of the parts of that act is the Medicaid expansion. You and I have been involved with this whole process for many years. We started as leading out groups, me with the business, and let's see, what group did you lead out initially with the healthcare reform in Utah?
Mine was kind of a market reform, trying to come up with more cost-effective products.
And instead of talking a lot about why we shouldn't do this, what's the federal government encroaching upon the jurisdiction of the state, instead of going into a lot of that, we want to talk about some of the actual implementation of Obamacare, the ACA, maybe some of the insights that you have with regards to what's upcoming for the citizens of the state of Utah with regards to this new, this greater control now of our health care from Washington, D.C. But let's talk about Medicaid first. Next week in the Health Committee, you're going to be talking about Medicaid expansion and 3 options. Tell us about what those options are.
Okay. One of the options is to not do the optional expansion. There is a mandatory expansion that the federal government is requiring that states do, and that's generated by eliminating the asset test. Right now, for certain categories of people, there's an asset test, and even if you have low income, if you have modest assets, you're not eligible for Medicaid. Come January 1, the asset test is eliminated. So we estimate that we'll have 51,000 additional Utahns eligible for Medicaid. Even if we do not do the optional expansion, they will be eligible under the mandatory expansion. So one option is to not do the optional expansion. That's a choice of the Supreme Court. ruling last year gave to the states. So if we don't do the optional expansion, we still anticipate about 51,000 more Utahns enrolling in Medicaid with the elimination of the asset test. And that mandatory expansion, of which we have really no choice, is estimated in 2020 to cost the state about $26 million in today's dollars. So we're looking down the road, what will it cost in today's dollars? So that's another $26 million that we're kind of being handed to by the federal government. Well, not the money, the requirement. The second option is what we're calling partial expansion. Partial expansion is expanding Medicaid from 0% of the federal poverty level to 100% of the federal poverty level. So that's a partial expansion. It goes from 0 to 100, and we anticipate an additional 40,000 Utahns would be eligible under that. So we have 51,000 under the mandatory expansion. We have an additional 40,000 if we do a partial expansion from 0 to 100, and that would cost the state an additional $16 million at the point when the state has to pay their 10% share of it. The federal government has said for the optional expansion, they will pay 100% for the first 3 years, and then it phases down to they pay 90% and the state pays 10%, and that 10% will be about $16 million. So that $16 million plus the $26 million that we have to pay for the mandatory expansion, that gives us a total of almost $42 million. And then the third option is really a full expansion from 0% of poverty to a 138% of poverty. That would be full expansion, but it's using a subsidy where the people eligible for Medicaid would get a subsidy to purchase commercial coverage, and rather than just enrolling in the government-sponsored Medicaid program, they would get a subsidy and get a commercial policy. We anticipate that would add an additional 57,000 insureds under that, reaching those that would be eligible from 100 to 138% of poverty. So that gives us 51,000 under the mandatory expansion, 40,000 from 0% of poverty to 100%, and then under this third option, an additional 57,000 from 100% of poverty to 138. And that will cost the state an additional $24 million. So expansion with the premium subsidy concept to 138% of poverty, that's going to take an additional $66 million of new ongoing funds from the state.
So is there some funds that we'd have to come up with, at least in the next budget session, should we choose to implement like option 2? Is there some commitment to the state?
There is an obligation. The state's going to have to come up with the mandatory expansion money, so we will need to budget for that. And then if we do, as you said, option 2, the partial expansion, the federal government is saying that they will pay 100% of that partial expansion for the first 3 years. However, they do not pay 100% of the administrative costs, which are going to be several $1 million, maybe $4 or $5 million. So even though the federal government does tout that they pay 100% for expansion, that's 100% of the benefits, not of the admin. So for this next year...
So it isn't completely free for us as a state?
What's that?
It isn't completely free for us?
No, it is not free. They're saying it's 100% covered by the feds. It's not really accurate because they don't pay 100%, but they pay about 50% of the admin costs.
So we'll continue this discussion. We're going to go to a break for a minute. Appreciate you being with us, Representative Dunnigan, and please stay with us, folks. Talking about the Affordable Care Act, ObamaCare. thanks for being with us.
You bet.
We're on a break now for 2 minutes.
Okay.
So I'd like to, if we could, maybe just talk about the Medicaid expansion a little bit. Is there a favored one that you'd like to see us do?
Well, so if we took a vote in the House today, I won't speak for the Senate. There's a bunch of people that would say don't expand at all. I think it may be reasonable to do option 2, the partial expansion. And one thing I haven't talked about, maybe we want to, is that above 100% of poverty, we can expand from 100 to 138 under Medicaid, but if we don't, from 100 to 138, those people can go on the exchange and get some really nice subsidies. So they're taken care of. So there's no rational reason to expand above 100%. Below 100% of poverty, they're not eligible for subsidies. That's kind of the donut hole that was created with the Supreme Court. Really.
Yeah.
But I would say we, as a starting point, now this is just between you and me for right now, but the option 2, even though the federal government is saying, no, we're not allowing option 2, we want you to expand all the way, I don't think that means we shouldn't try for it.
Well, that'll be, I know, a big discussion coming up. I'm wondering what the governor's going to do, and he's not revealing any cards at this point.
No, what we hope to do at the task force next week is narrow the 8 options that were presented by the governor's working group down to 3, so we can start lasering in on, instead of having so many options out there.
All right, we got 15 seconds to be back on the air. Welcome back to the Legislative Update. This is Senator Wayne Niederhauser, and with me for this segment, again, is Representative Jim Dunnigan, who represents an area of Salt Lake County. I think it's Taylorsville mostly, isn't it, Representative?
That is correct, Taylorsville.
And just kind of give you another little snippet about Representative Dunnigan. He's probably one of the foremost, if not the foremost, expert in the legislature on this issue of health care. I served with him as the chair of the Health Systems Reform Task Force for a couple of years. I know firsthand his commitment and knowledge of this area, so it's fortunate for us to have you here today. We were talking before the break that about if we were to choose option 2 as a state and move ahead with that, you would pick up those who in the expansion population that are in the poverty level up to 100%. And some of the advantages of that, I think as you were saying, is that now those folks would be able to go to the exchange.
From the potential expansion of Medicaid is from 0% to 138%. However, at 100% of poverty, from 100 to 138, those people are eligible to go to the individual exchange and get the biggest subsidies available, because the lower your income, the biggest the subsidies. However, subsidies only start at 100% of poverty. So between 100 and 138, those folks can go to the individual exchange and get the very best subsidies available. From 0 to 100%, there is no subsidy available in the exchange. So that's where option 2 steps in. That would expand Medicaid to cover the Utahns between 0 and 100% of poverty that aren't eligible for exchange subsidies, and option 2 would offer Medicaid to them.
Yeah. Okay. I think that's pretty clear. That option 3 then, or option 2, allows those who are from 100 to 138 to go to the exchange, get subsidies, but we'd be covering all those who are under 100%. But the question still is out there. Are we now going to expand and take more federal money? And that's probably a discussion for another time. We've had that discussion on this show in some previous meetings. Um, let's talk about the healthcare exchanges for just a minute. I know that you've been heavily involved with that. Utah was a leader in the nation, only the second state to have an exchange, and this was even before the Affordable Care Act. Our exchange was focused on small business, not individuals. With the Affordable Care Act, there's an individual exchange and the small business. Can you kind of give your take on what's going on out there with the federal exchange, some of the problems that they're having? What's your understanding of what's going on?
Well, to be succinct, it's a mess. And Utah elected not to operate the individual exchange for a variety of reasons. We had concerns that the federal government would have their piece of it ready, even though the states could elect to operate the individual exchange. You have to interface with a federal data hub, which is multi-federal agencies such as IRS, Department of Labor, CMS, to verify a variety of things. If people have legal residence, what their income is, and so forth. And we had real questions about whether or not the federal government would have their piece of it ready and whether or not the data would be secure. So we said to the feds, we'll do the small business exchange, you do the individual exchange. Well, the federal government opened the individual exchange on October 1st for people that want to buy individual or family coverage, not through an employer. And it has not gone well. They did not adequately test it before they opened the doors. So they've had numerous problems, and it has gotten better in the last month and a half. But we just got a report yesterday that so far fewer than 400 Utahns have signed up for health insurance through the individual exchange. We've had over 4,000 enroll for Medicaid, but only less than 400 have enrolled for coverage in the individual exchange. And nationwide, it's about 50,000. They were hoping for 500,000 by now. And so there are many, many problems that they were not ready. There's a lot of different computer systems that have to engage each other. They did not do adequate testing. Just a week prior to October 1st, before they flipped the switch to open those doors, electronic doors or internet doors to shop, and their testing then, once they hit 1,100 users at the same time, it started to fail. Well, they had tens of thousands that tried to access it on October 1st, but they knew the week prior to October 1st that at 1,100 simultaneous users, it was failing, and yet they still went ahead and opened it. Numerous people, even supporters of the Affordable Care Act, suggested take more time, get it right, do some testing. They chose not to do that.
I think if they would have called us, which may have been a smart thing to do, hey, Utah, Massachusetts, they've done an exchange. Maybe we ought to talk to them about an implementation. I think one of the first things that we would have said is do a pilot first. Maybe do a pilot for a year with a small segment of the population, get the bugs worked out, and then implement it completely, because we had similar problems, correct?
Yes. When we opened our small business exchange, there were problems. However, Utah did it differently. We did just what you suggested. We did a pilot program. We allowed a very limited number of employers to participate in our employer exchange, and they were the beta test. We ran that for a number of months before we opened it to the general employer population. And the federal exchange should have done that. I mean, that's obvious. You just don't open this big of a program, throw the doors open all at once when you have never beta tested it.
So, we hear that things are better now. Is that, I know you're in that industry quite a bit. I don't know if you're trying to help people get through that exchange. Is it getting any better?
It is. It still is not adequate. Yes, we try to enroll. We try to enroll people in it every day. And yesterday, successfully, somebody, and we went back on 30 later, and was not get a lot of error messages. It's overly complicated. Basically, what you're doing, if you go onto the federal exchange and apply, you're first applying for Medicaid. And that's one of the reasons we chose not to operate it, is because they mandate that if a person wants to go and buy health insurance, you have to first see if you're eligible for Medicaid. And if you are, you go through the Medicaid door. You're not eligible for a subsidy to go out and buy a commercial policy from Blue Cross or United or Altius or Select Health. That choice is not yours. You can't get a subsidy to do that. You have to go on Medicaid. And so everybody has to fill out what is essentially a Medicaid application. It's like filling out a mini tax return because it's based on your income, among other factors. And it's for a family of two, it's a 10-page application.
Oh, wow. I haven't actually gone on and looked at that.
There's
That's
no
amazing.
health questions. We used to have that lengthy almost, not quite of an application, but we had a detailed health questionnaire. Now there's no health questions, and the application is longer.
Yeah. Amazing. So for our listeners out there, there's the exchange. Hopefully they'll start to get that right, although it seems to be complicated. And that's probably the reason for the low numbers going on the exchange. What can the citizens look forward to this next year with full implementation of the Affordable Care Act? I know that a lot of our listeners already have insurance through an employer. What are some of the things they can expect? Are prices going to rise? I know I've heard from a number of people that they're seeing 30% increases in their insurance rates this next year.
For my clients, as we're looking at their renewal rates that we're now getting for January, February of next year, the rates are going up. There are new taxes that are coming into effect as part of the Affordable Care Act. Starting in January, there's a premium tax, and that in itself is going to raise rates probably 4.5%, just that. So, and including in that another tax that's coming into play called the reinsurance tax or fee. But in Utah, in general, we don't tax health insurance premiums because we know that just causes the cost to rise. Well, starting next year, there are a variety of taxes from the Affordable Care Act that are going to be assessed on premium. Over 10 years nationwide, that's going to be over $100 billion that will be collected, which is just going to cause our premiums to go up. So premiums are going up next year, partially due to taxes, partially due to additional benefits that the federal government is mandating to be covered.
So it seems to me this whole idea that this is the Affordable Care Act is kind of an oxymoron.
Well, I'm not sure who it will be affordable for. There are people that are getting subsidies, and so if you're one that qualifies for a good subsidy, even though the rates are going up, the subsidy will bring your net costs down. So yes, it will be affordable for you, but other people are paying taxes in order to make it more affordable. And some of the health insurance carriers, when they give their renewal increases, are saying, this is how much we need to cover your claims, and this is how much the additional taxes of the federal government raises your rates. And for example, I presented a 11% increase to one of my clients for January, and 4.5% of that's the federal tax. And that's just a brand new increase in rates that we haven't had before.
Well, so our Congress and our president who enacted this new law, the ObamaCare, they didn't necessarily come out income taxes, but behind the scenes, we're all going to be paying more for our health care, and which in my mind is another tax, and really a tax. So segment being with it, keep in the internet next week. Thanks for being with us.
Thank you, President Niederhauser. Appreciate it.
Stay with us at the legislative update for more information on the Affordable Care Act. I don't do pretty. Gray hair, yellow teeth. Senator?
Yeah. Fine, thank you.
For being here today. It's
Not
been
a
an
problem.
interesting experience for me.
I'm trying to find the video and I can't find you.
Yeah, UtahTalkRadio.com or 15 a.m. video would probably be maybe difficult up in August.
Yeah. Called her impossible. One of the two.
The source of the signal is in Spanish Fork.
That would.
This is going to be a great opportunity for us, I think, in session, because we're going to broadcast this every week during the session on Thursday morning. So it'll be a great opportunity for a lot of us to get our message out, talk about the legislation facing the session. One of these whole healthcare thing. So I've got you down for check care, expulsion, implicate state and local governments. I know I've been heavily involved in this, but we might talk about your perspective first, just on Medicaid Expansion. I know you've been in that and the pros as far as what you see.
Totally fine, yes.
So we got about 50 seconds before.
Okay.
Oh, you've been working on food storage?
No,
Kirsten's
shifting
here.
it around.
Okay.
My wife's had it stuck under the beds and in closets and everything else, and I finally better have a place in the garage to organize it. So.
Oh, good. All right, 15 more seconds.
The best for Utah. Check up lawmakers to listen here on AHN. This is Utah with President Wayne Niederhauser and guests. If you have a question or comment, please call Canyon Studios at 1-800-766-113, 800-776-113.
Welcome to our program. This is Wayne Niederhauser. Again, we want to thank Representative Dunnigan for being with us. He's the foremost in the legislature. Healthcare. He's been involved, an insurance agent, knows ins and outs of how this of the the new Affordable Care Act. With me is one of the legislators that are most in the front of this issue, Senator Allen Christensen from North Ogden. This morning. Welcome, Senator.
Thank you.
It's good to have you with us. Let's talk about Medicaid expansion from your point of view. We talked a little bit about Representative Dunnigan and the option we probably will be facing, or the committee facing. What's your take on Medicaid expansion? You've been right in the middle of this.
Well, in my estimation, it is amply what it is rearranging the chairs on the Titanic. We have a system that is broken, that is pushing the American public toward socialism, and now in Utah, they're suggesting we sign up another 160,000 eligible people onto the program, and they're quoting all of these are the people who are encouraging us to expand completely to to expand it and put all these other people on, yet there are unanswered questions, and that is, where are the providers going to come from? Because though it puts a lot of more bodies in the system, it doesn't allow for any more doctors out there. So how are we going to handle all of those people? Anyone who tries to get an appointment with their family doctor these days knows how long that takes to wait, and that portion of it scares me. Also, those that say, well, the government is going to take care of the cost. We're the government. Somebody has to pay those costs. And though I would love to just give everything to everyone out there as far as health care, I can't force other people to pay the bill. And that's what it amounts to.
I don't think there's anyone that I know of in the legislature that understands the humanity like you do. You've been the chair of our health care of Health and Human Services and Social Services, as we recently called it. You've seen a lot of humanity over the years.
Well, as a pediatric dentist in my professional life, I've served the public for 40 years, and many Medicaid patients have come through my office, and we've taken care of them to the best of our ability on a non-biased in a non-biased manner. And I've seen the need out there, and the humanitarian part of me says, gee, I would just love to make health care a right that everyone has, yet that ignores the basic fundamental part that says someone has to pay for this right that people want. And I'm afraid that I view it more as a privilege. The whole American experiment was founded on the basis that people can take care of themselves. They have the right to go out and not be biased against for whatever reasons, and make themselves a success or fail. But there were no guarantees when we started that said, and if you fail, don't worry, somebody else will come along and we'll make them pick you up and help you out. That just goes against my way of thinking about the American experiment.
And now what we're trading off for is the control of our health care from a central government in Washington, D.C., where at least prior to the Affordable Health Care, most of those decisions would be made right here in Utah at the legislature here, where people have more input. But now a lot of that control is going to be dictated from Washington, D.C.
Well, whenever you take a dollar from someone or a favor from someone, you have the strings that get attached to it. And the government is definitely no exception to that. So when I take a handout from them, I have to play by their rules, and they're not necessarily the rules that I, for one, would establish. There are abuses of the system that are rampant, and the federal government denies us as Utahns the right to correct those and run them as we see fit. They set the rules, they hold the purse strings, and that part of it also very much scares me, putting the federal government in charge of my health care and what I think that I deserve and need.
And because of their taxing authority, I guess we could say they hold the purse strings, but really it's the purse of every citizen in this country and in this state that's paying for this, and government from Washington, D.C. You highlighted an interesting issue with the Affordable Care Act that I don't think is talked about a lot. The supply of health care. Will we have enough providers now that there's more demand and more access? And I've actually been beating this drum for quite a number of years, saying we're running headlong into natural law. Natural law being things like gravity, things that that we can't legislate over and function regardless of what we think we can control. And one of those is supply and demand. It functions naturally. And when you address demand for health care, more demand, and not address supply at the same time, what happens to the cost of health care? And this has, I think, been part of the problem for many years and the reason why the costs have gone up, which cost is the biggest problem why people can't afford it, why people can't afford health insurance. Maybe you could just highlight, what you're seeing with, you said that, do we have the supply? Is that just in your area? Are you seeing that in the medical profession, primary care?
No, we don't have nearly the supply that we need. First off, everyone assumes that since they're now going to have medical insurance or Medicaid, as you will, that they can go wherever they want to. Well, currently, there's only a fraction of the healthcare providers that will accept Medicaid, and for that matter, even many of the insurances will they accept. So as far as just the Medicaid portion of it goes, we put all these hundreds of thousands of new people into the system. They're going to feel then that they're covered. They have the right to go out and use it and have someone else pay the bill with very little responsibility on their own, according to the Medicaid thing. The supplier, the providers of the services are going to remain approximately the same as they are now, or perhaps even less. If you have a lot more people that are insured, there is nothing that says the physicians, the frontline providers, the primary care providers have to take Medicaid patients. And with the new supply of insured patients, why would they want to take care of the patients where they only get reimbursed a fraction of their normal fees?
So, go ahead.
We would love to think that all doctors out there and dentists and healthcare providers are all in the business for humanitarian purposes. And indeed, that is a huge portion of what they're there for. But healthcare is also a business. And when the end of the first of the month comes and you have your payroll to make, it's nice to be able to have sufficient income from your profession to provide for that. And when one is offering you $100 for the service for an insured patient, and a Medicaid patient, on the other hand, you're going to get paid $30 for the same service, you are going to tend to accept the $100 patient and provide that humanitarian service for them rather than the one who only pays you a fraction.
And as a provider, I think you're highlighting one of the biggest issues that we'll face with healthcare going forward, because as ObamaCare, the Affordable Care Act is fully implemented, and they find that there's this dynamic taking place, that the supply out there doesn't want to provide because of the low cost, they're now going to want to control providers. So we're coming up to the end of this segment. Thanks for being with us, and we'll be back with Senator Christensen talking about Medicaid expansion, the Affordable Care Act. We'll talk about charity care and the high-risk pool in our next segment. Stay with us. So I think that's the next step, Senator, is they're going to figure out, well, this isn't working, so now we need to control providers more.
I think it is. And I think they're pushing to a single-payer system where insurance will totally be gone. Everyone will be treated exactly, quote, equal, and the providers will be dictated to. And that's going to decrease the pool even further, because fewer of the best and the brightest are going to want to go into medicine, because they're being then controlled, and the motivating factors for getting in there and being a good humanitarian and being your own boss are going to be gone. And those are other things that scare me. Are they on the horizon? Oh, yeah, I think so.
Yeah, absolutely. I see that completely. And they tip their hand on this one.
Mm-hmm.
We've seen those that I got onset of in Boston, the way that with the continued budget on providers reimbursement rate.
Yep.
So it's not just still at some point to control that the provider. And yes, we'll treat it equally with quality care.
In an unequal system, we'll all be treated equally.
Yeah.
It simply doesn't work.
Yep.
So how did you get in on this thing?
I'll tell you at the end. We got 5 seconds.
Okay.
Quando sono solo sognarò che sì, lo so che non c'è stanza mancato se ci sei.
Back with the legislative update, with Senator Christensen. I think we were talking a little bit about some of the dynamic place here. As this doesn't work, they want to control the reduce the reimbursement rates. That hurts the supply of health. People, those individuals that profession may not want to do that because of the control that's happening from Washington D.C. and senators say, yeah, we might be equal in our health care at that point, but the quality is substantially less, and an access or having the health care when we need it might not be available when you have a limited supply.
That's right. When you take away that portion of the supply and demand picture, the government is going to be forced to step in and dictate once again who can do what and when and how, and take over more and more of the responsibilities. And that time-honored profession of being a physician is going to suffer from it, because people will be less inclined to want to go into the field when they're being dictated how they can practice and where. And are these all just worries? They're very strong concerns on my part, and very real possibilities.
So, high-risk pool. Let's talk about that for a minute. I think that might be a new concept for people out there listening. Utah has addressed some of the unhealthy folks that get insurance through what is called the high-risk pool, where the state subsidizes premiums for some of the folks there that have some of the largest or some of the most extreme health situations in our state. Now that will eliminate. What is the result of that? What are the implications for us as Utahns?
Well, previous to this, some people who had, say, a bleeding disorder, who had hemophilia, who had AIDS, who had any number of things like diabetes, the insurance was allowed to discriminate there and say, you are too expensive, and so we are going to increase your premiums to offset that. Insurance is a business, and they have to make their bottom line work out. So these people were put in a special area, and the state helped them out so that this would be affordable. Now, with the new Accountable Care Act or ObamaCare, those people will all be treated equally. The number of risk factors will be reduced greatly. If you're a smoker, they can still discriminate and give you a higher rate, and a couple of others, but no pre-existing conditions will be allowed to be considered from here on out. So the young immortal who's 21 years old and healthy and strong will be forced to pay basically the same premium that the person who has diabetes or AIDS or one of the other factors, and they will have to be considered equally as far as the rating goes. So there won't be any need for the high-risk pool anymore, because all those people will be thrown right back into the common mix. And you can imagine what that will do to the insurance premiums. The people who were in the HIP pool are going to say, hooray, we don't have to pay nearly as much. But the part that they were having to pay is going to be divided out amongst all of the other more healthy group.
So part of the reason why a lot of folks out there are seeing on their renewals coming up for next year a pretty hefty increase in their premiums, part of it's due to this community rating issue, and now the spreading of the costs of some of the things that we've been taking care of, at least in the state of Utah, in our high-risk pool.
That's correct. And, I get people all the time that tell me, why don't you make the insurance companies force them to pay for such and such, or for this problem or this problem? Insurance companies are a business. They are in it to make a dollar, like all the rest of us out there. And if we force them to pay for an additional thing, someone has to pay the bill, and so they spread it out over the other population that previously weren't affected with that particular problem. So the HIP pool will go away.
Charity care, I know this has been a discussion through the interim. I think in America, people would not accept watching on TV somebody not being able to get the health care that they need. We're a very human-oriented nation. We wouldn't allow that to happen, and that's the reason why we have a lot of these programs today, although they may have run amok. What was intended to be a charitable situation now has become such a safe net that there's no ability for individual. What are some of the solutions that maybe we could look at with regards to charity care?
I could carry on the discussion on charity care for the next week with you, but I'll try to narrow this down a little bit. In my own practice, in my own office, we did an enormous number of patients for free, but I also had the liberty of picking and choosing, and I did not have people walk in the door and demand free care and be forced to give it to them. That isn't charity. That's coercion. The charity care, first off, the subcommittee that under the Health Reform Task Force, the subcommittee on charity care, worked long and diligently to try to come up with some answers on this. The first problem we faced was, what is charity care? Define it. And we had a difficult time with that. I came up with a new acronym of FACTS, financially assisted care and treatment. Not that we need another acronym in the government business, but any time, in my book, any time that you are receiving something that is financially assisted, whether that is a sliding scale, whether it's completely free, or whether someone just steps in and pays your copay, I consider that charity care. An interesting little anecdote here. I was told that we have the 4th Street Clinic down in Salt Lake that provides a huge amount of free medical care or sliding scale medical care. They had a problem down there because the homeless people were sharing the same area with the low-income people, and the low-income people were objecting because they weren't homeless and they didn't want to be associated with the homeless people. And I have to chuckle at that a little bit because someone is paying the bill for both, yet their self-identification was being affected here, and they didn't want to be on a lower scale than they actually were. And so in defining what charity care is, I would rather call it financially assisted care. Now, we have a huge network of charity care providers already existing within the state, and we've sent out I'm missing the word here, a questionnaire to these charity care providers about the number of visits that they provide, where their bills are being paid from, what their budget is, the population that they served, and the volunteers that they're utilizing. And the number that I'm coming up with an incomplete survey at the moment and extrapolating some of those figures, is about 2 million patient visits a year that are being provided currently under charity care. Now, with the new Accountable Care Act, there are going to be an enormously increased number of insured patients out there, and there will be a large increase in the number of Medicaid patients also. Without even the optional expansion, there will be a lot more people on Medicaid because of the new rules. This means that the uninsured population is going to be decreased significantly. And I personally feel that we have the structure in place currently, especially with a little bit of tweaking, that we can provide the financially assisted care for the uninsured population in Utah within our own existing framework. There will have to be some tweaks to the system. Some areas may need a little bit of financial aid, some with legislative assistance, as far as one that I'm working on this year, the liability, the malpractice insurance for these providers who are giving free care. And this relates back to our discussion about the provider pool.
Well, Senator, we're winding down here. I think you highlight, though, that charity is something that is optional and out from the heart, not actually mandated. So thank you for being with us on our show today. I appreciate you being with us. Be with us next week for another show on the Legislative Update. So sorry to cut you off there.
I'll call him.
Okay.